Hello, everybody, and welcome. My name is Dr. Gary Sibbald, and this session is sponsored by Perfuse Medical and Technical, and we are going to be talking about edema and the geko device. In short, the first two speakers are Robin Evans, who is the medical director of the Wound Healing Clinic at Women's College. She's a family doctor and a consultant to Wounds Canada on interprofessional education programs. Kathy Burrows, we're proud of Kathy because not only is she a consultant for Perfuse Medtec Incorporated, she was one of our first graduates from the Masters of Science in Community Health, Wound Prevention and Care in the IWCC, and coordinated a leg ulcer clinic, and she's a clinical advisor to Wounds Canada. So our session today will talk about time, edema, and other impediments to healing. Why is this important to wound care? So Robin and Kathy, you have the floor.
Thank you, Gary.
Thank you very much, Dr. Sibbald. Thank you to geko for inviting me to talk about this important topic. I think edema is something both clinicians find very daunting and patients really don't like. So the objectives today are to assess the etiology and the pathophysiology of edema and its clinical implications, and review the role of geko device as the first-line adjuvant therapy in the treatment and management of edema and wounds. We want to recognize how important it is for the early intervention in wound healing in terms of managing this edema. This is a thought-provoking question. I just want you to think about which of the following about edema is false. Edema can be a result of venous, lymphatic, and arterial issues. The kidney plays a major role in fluid homeostasis, and prescribing furosemide is effective in managing venous insufficiency. And can edema be a sign of DVT? So I just want you to think about this. We'll wrap up at the end with a discussion on this quickly, but we'll start talking now about the pathophysiology. So what is edema? I mean, we see it, we talk about it, but it's actually swelling produced by expansion in the interstitial volume. And this happens in many body and organ systems. We know it as leg edema or peripheral edema, but when it occurs in the heart, it's pericarditis. In the abdomen, it's ascites, and in the lung, it's pleural effusion. These are all similar processes that are going on. So how does it all happen? So this is really the most difficult slide, maybe. I'm going to try to simplify it. I want you to understand edema just sort of from a concept point of view and hopefully not have to memorize anything. So looking at Starling's law, and if we were in an auditorium, I'd probably say how many people know or understand Starling's law, and probably if everyone was not lying, they'd put up their hands. This dates back to 1896, and recently it's been revised to suggest maybe this isn't all of what's going on in the capillary bed in the interstitial areas. So if you look at this diagram, which I got permission to use, the top end of the arterial end of the vein at the top there, you see hydrostatic pressure, and that's how fluid goes into the interstitial space, by this hydrostatic pressure. It bathes the tissue, the metabolites are necessary for cell metabolism, and at the other end, oncotic pressure pulls that fluid back into the capillary and returns it to the heart, which is very important. That oncotic pressure is really protein that exists in the capillary bed to pull that fluid. So you can see we need hydrostatic pressure to take it in, oncotic pressure to take it out. Now, what's new with this is that people have looked at mathematical models and done a lot more investigation and realized that it's not quite as simple as that, because there's a glycocalyx lining of that capillary bed, and fluid actually doesn't always move like this. We got that little green creature in there, which is the lymphatic system, and that lymphatic system is a bed similar to the capillary bed. It runs in series, and in fact, much of the fluid doesn't go back and forth like this. A lot of it is going back through lymphatic capillaries, back through the thoracic duct and return to the system. And in fact, it can be up to 8 liters a day. So really, Starling's law has been revised. We have, yes, the oncotic pressure and the hydrostatic pressure, but we also have a major component of the lymphatic system helping in this system. Next slide. Okay, so just simply, I want this to be easy for everyone to understand. Fluid issues can be localized or they can be systemic. So if we think of the total body fluid, that would be the sink on the right-hand side, it's overflowing. So that's one issue. The other issue is a more localized system, like you see in the pipe underneath the sink, where we have fluid just not being managed by what we have there. So that's more analogous to our peripheral edema. So what do we do about fluid? And I think a lot of us just jump to, okay, how can we stop this fluid from coming out of the leg? What are we going to do? There's lots of dressings. We have superabsorbents, gauze, abdominal pads. But I think you really have to think about it. We're not able to stop a pipe by wrapping a rag around it. And similarly with edema, we're not going to get rid of it by just packing on stuff. We have to really think about the cause. So the causes really can be defined by three things. So volume overload. This is analogous to that increased hydrostatic pressure that we talked about a couple slides ago. So it's overwhelming to the system. And the most common causes of this would be congestive heart failure, renal disease, and venous insufficiency itself, because we've got too much volume in the system that's not moving around. Low protein states. This is the oncotic pressure. So things like renal disease, where you're losing proteins dramatically in the urine, malnutrition, liver disease, and GI specific issues. And these would be quite common, and you could see fairly in Crohn's or any kind of inflammatory bowel disease or major GI surgeries. And very important is damage to the capillaries and lymphatics. This happens a lot of the time through trauma, surgery, or loss of the lymphatic system. In fact, anybody who's had breast surgery and lymph node dissection, lymphadenopathy is very common. But even small bits of trauma, if you sprain your ankle, patients later on, a couple months down the road, can have ongoing swelling at that area, not from the inflammatory reaction anymore, but damage to the lymphatic tissues. And of course, because we see an aging population, a lot of the times what we see here is a combination of these things. So really there's three causes, but then we need to look at what we're actually seeing clinically in the office or the clinic. We see, what are we looking at, whether it's chronic or acute, because this is also going to help us with our diagnosis. I think much of what we see is chronic. Chronic edema, either unilateral or bilateral. So unilateral, we're thinking more of venous disease, lymphedema, and pelvic neoplasms always get mixed in here, because if you have any pressure in the pelvic area, that's going to delay your venous return, any fluid back up the hill, and you can see increase in edema. Bilateral edema, also venous disease, heart disease, lymphedema. The acute stuff we see, I think most of us may be acute on chronic, but you can also see acute itself. Acute unilateral, never forget a DVT. This is obviously important to your patients as clinicians to prevent morbidity and mortality, something you need to think about. Cellulitis can happen, Baker's cyst, which can present like a DVT, a pelvic mass again, and May-Thurner syndrome is just thrown in there for maybe your Jeopardy lovers, but it's just an anatomical abnormality at the iliac vein at the top of your groin there. Acute bilateral, this can be medication. So medications that we think of would be calcium channel blockers, corticosteroids, non-steroidal anti-inflammatory drugs, acute heart failure or nephrotic system. And again, DVT gets thrown in there. It can happen bilaterally. Patients with malignancies may have a DVT bilaterally. So if we now focus our attention more to the lower leg and just look at venous insufficiency, think about this question. Venous insufficiency is a result of 1, a DVT, venous incompetence, calf muscle pump dysfunction, standing, sitting for long periods of time, or 5, all of the above. So I think most of you would get the answer is all of these things. And I'm just going to go through and discuss each one of these and how it contributes to difficulties in the lower extremity. So venous return. So this is a diagram showing how your valves should work. Blood should flow from the superficial venous system through perforators to the deep system, and by a progressive movement up the hill to the heart. That's in a perfect world, but as we stand or we sit all of our lives, gain weight, obesity, anything that increases downward pressure can cause that vein to increase in size, and the valve's no longer going to close. And you get the third picture here, which is dilatation of the vein. Possibly you'll see varicose veins, but now it's not a unidirectional system, and fluid can go back and forth, and that leads to this venous hypertension. If looking at this slide on the right-hand side is an example of a patient who's had a knee replacement. And you can see the calf isn't very developed there, and you've got a venous ulcer on the medial side of the leg. This is an example of failure of the calf muscle pump, which is so important in moving that fluid back up the hill. And what you need is you have to have dorsiflexion and plantar flexion of that foot to get movement of fluid back up. So anything that could affect the calf muscle pump, that could be knee surgery, hip surgery, ankle injuries, arthritis, anything that prevents dorsiflexion and plantar flexion of the foot. So we can also think of things like Parkinson's disease, a shuffling gait, as well as some of our patients using rollators, all may be contributing to this process of lack of the calf muscle pump. The picture on the other side, is just an example of what happens in the end once we don't see all this happening. We get this chronic change of the leg, which is what we want to prevent. Stasis changes produces stasis dermatitis and this woody fibrosis with hemosiderin deposition, and the development of, starting to develop here, the champagne bottle deformity. So the last cause here is DVT. So DVT is considered an obstructive cause of long-term venous insufficiency. And a lot of our patients who have had DVTs, down the road, you're going to see changes in the venous system and the development of some of the changes that you see with venous disease. And often these patients will end up with ulcerations. So it's a point of prevention here for patients who've had DVTs to jump on this right away. So DVTs are easy to diagnose if you think about it. You do the test, which is available easily in most outpatient labs. And in this diagram, you can see DVT in the top panel, and in the bottom panel, you see the dilatation of the vein and the varicosity. So this is some place that we as clinicians can intervene and hopefully prevent some of the changes that result from an obstructive cause like a DVT. So we want to prevent this stuff, because what happens as a result of edema is disabling for the clinician as well as for the patient, more importantly. So the skin changes we see, hyperpigmentation, possibility of cellulitis is very common, pain and quality of life issues. Patients don't like edema, it's uncomfortable, shoes don't fit, pants don't fit. And the reality is, once you start getting this swelling of your lower extremity, you really can't activate your calf muscle pump very well, because you can no longer move that ankle very well. So it's a bit of a vicious cycle. And then down the road, it's ulcerations and infections, which really cause a lot of issues for your patients. So why does edema and infection, why are they related? Well, there's a number of different causes for this. So these stasis changes, you get breakage in the skin barrier and entry. It's a portal of entry for bacteria. So staph and strep are very active in this department and can cause cellulitis. Edema fluid actually neutralizes fatty acids on the surface, which is your natural bactericidal agent that helps to protect the skin. So edema fluid actually is a contributing factor for this. Poor perfusion is very important. When you get any kind of edema, you get delayed wound healing, and this swelling actually, you get less delivery of the important chemicals to fight infection if you do get a breakage. So poor perfusion is important because of just distance of the arteries and the good stuff, as well as the cells to fight infection. Tinea pedis is really common in terms of what causes cellulitis, and something that we should all be checking for, particularly when there's edema in the lower extremity. So this is what we're preventing. This is a long-term effect, and prevention is key to this. When we're talking about edema here, we're really talking about the causes of edema. We're really not talking about exudate here. Exudate's a different topic. Some parts of exudate can be from congestive heart failure due to blebs, but really exudate's a different topic, but this is the end product of what's really gone wrong with chronic ongoing edema. Now, I just want to put this all together so we understand everything that's going on. This is a typical example, which you'll see, of Mr. HF. He has a history of recurrent bouts of congestive heart failure, and as a result has peripheral edema. So he's got the whole thing going on here. He's got this increased hydrostatic pressure because of volume. He's got now developing all this changes in the interstitial space, the hypertension and the inflammatory changes, low oncotic pressure, and damage to the lymphatic system because of this ongoing issue of inflammation in the interstitial fluid. So long term, we've got the whole 3 mechanisms here that are going on to damage the tissues and the lymphatic system and contribute to this edema. And finally, edema. This is what happens with congestive heart failure, with this just pure volume overload. Skin is shiny, you can almost see the fluid in the interstitial space, and this blistering reaction as a result of it. And this is typical of cardiac failure and low serum albumin. Arterial edema, just to be complete, we do see edema related to just arterial disease. And if you look at this picture, there is edema here. Sometimes it's more pronounced than this, but you get dilatation of the capillaries instead of constriction. And of course, this contributes to the edema and the redness that we see with arterial edema. So also to remember when looking at the lower leg for swelling. So to how to manage edema, obviously, if we manage it well, we won't get to those complications. So most importantly, identify the cause. We went through the 3 major causes and some of the acute and chronic things to think about. Compression therapy is the gold standard, and we really need to do a better job of improving the calf muscle pump. And in an ideal world, physiotherapy and getting patients more involved in this would be ideal. So compression therapy, it's wonderful. We use it, it's great, but it's not. It has its issues, and I'm going to now turn it over to Kathy to talk more about that.
Thanks, Robin. So the big question is, how does the geko device reduce edema? And this is not a polling question, but just a review question. So by changing the volume and velocity of blood flow, decreasing venous pooling, eliciting muscle contraction of the calf muscle and foot, and increasing fluid into the tissues. So the response is actually 1, 2, and 3. The geko device will increase the volume and velocity of blood flow, decrease venous pooling, elicit muscle contraction, and of course the 4th one is a trick question. It doesn't increase fluid into the tissues. So this is a image of a speckle spectroscopy, and speckle spectroscopy is an optical method for measuring blood flow, arterial, venous, and microcirculation. And this particular slide was provided by Dr. Keith Harding. And you can see on the left, inactivation, and then with activation of geko, there was quite a bit of increase, 225% increase in the flux to the wound bed, and 67% increase to the peri-wound skin. And this just is another video that shows the venous sludge index. And once geko is activated, it's reduced from 53.5 to 7.6, and you can see that it is statistically significant. So edema, there's been some studies that have been completed. Baker et al., they looked at 20 patients using geko preoperatively before ankle surgery. And 60% of the patients were ready for surgery in 2 days compared to 27% in the control arm, which was an improvement of 122%. The standard treatment was 3.66 days readiness for surgery versus geko and plaster cast, which meant that there was actually 2 days improvement. Ingves and Power reported 2 cases of multifactorial and refractory leg edema successfully were reduced by 7% and 21% respectively with the geko device. And this is a randomized controlled trial that was conducted at London Health Sciences Centre in London, Ontario, and they looked at 221 patients post-renal transplant IPC, intermittent pneumatic compression, versus the geko device. And the results show statistical significance in all of the parameters. Leg edema at the calf was, the circumference was 3.6 centimeters versus 2.5 centimeters with geko. Weight gain was 5.18 kilograms versus 4.06 kilograms. Urine output total was 12.6 liters versus almost 16 liters with geko. Wound infections had reduced 29% with IPC versus 7% with geko. And an overall cost with having the patient discharged earlier was $2,300 per patient, and that's in Canadian dollars. And this is just an example of my personal experience of patients who come into clinic with compression. And obviously this just demonstrates that they all wanted their heel exposed because it was hard to get shoes to fit. And this just demonstrates that they have absolutely no compression when it's like this. And this is just an example of a patient who had TED stockings on for post-operative procedure, and obviously the TEDs were not fitted well, and it ended up like a tourniquet effect. So moving the fluid above or below the compression, we all see this. What happens is that you get skin irritation, there's discomfort, mechanical issues, and you can possibly have nerve damage. But the big thing is forefoot edema, swelling, and swelling above the knee. And this is where we can get into some issues with skin breakdown and infections. And this is an example of what happens when we put too much squeeze on without properly applying an absorptive dressing. There's a great deal of maceration, which results in dead skin and further breakdown. So Robin, this is your question.
Okay, so we're back to this, and hopefully from this talk you'll recognize the answer here is prescribing furosemide is effective in managing venous disease. Well, based on the pathophysiology, we know that for venous disease, it's just an issue in the lower extremity. It's not a total body issue. Furosemide is a strong diuretic that acts at the level of the kidney, and it gets rid of a lot of fluid, but that fluid's a total body fluid, not related to the venous insufficiency. Edema can occur both in the venous, lymphatic, and arterial system, and we know that edema is an important sign of a DVT, so hopefully everyone got the correct answer, but I find clinically furosemide is used quite a lot to deal with venous insufficiency, and probably shouldn't be. So the take-home message today is I would really try to reinforce that history and physical exam should really elicit the cause of the edema. The lymphatic system does play a very important role in this. It's not just the venous. And complications of edema, including venous ulcers, are very significant. And there are other options to manage this. And I think these new studies with geko device do provide us with an alternative for fluid management. And importantly, too, we do see that now the geko is, at least in Toronto, on some of the LHINs, and an alternative that we are able to use now. So it's in the toolbox, just like a lot of different things for us. And so it's one of those things that you can think about using either alone or concurrently with compression.
Thank you very much. And you know, with 2 minutes to spare, I have to call you Zoom stars. And you've done very well. And I think those were very informative, especially the data pre-publication on the renal study. And I think that that's important, that we really got data rather than shadow. So it's my pleasure to introduce Rochelle Duong. Rochelle is the third out of the first three speakers. That's a graduate of the IWCC. She also has a Master's of Health Administration, and she is a critical thinker and a strategic leader. She's done an outstanding job in my home LHIN, Mississauga Halton, in terms of the wound care program and quality improvement initiatives. Her co-speaker is Carol Rabley-Koch, and Carol has a science degree, Bachelor of Science in Kinesiology from the University of Waterloo. She also has diplomas in alternate healthcare, and that's interesting. I have a son in alternate healthcare. She is a nurse specialized in wound ostomy and continence, and has worked for 25 years in the community setting. She is also an educational consultant with Perfuse Medtec. Ladies, we look forward to your presentation. Just make sure you're unmuted and that your picture's up. Okay.
Thank you so much, Gary. Thank you. So welcome everyone to our talk, and during this session you will have an opportunity to review how the collaboration between industry and the Mississauga Halton LHIN contributed positively to our policy and procedures, specifically as it relates to geko. You will have an opportunity to recognize the impact of using a validated risk assessment tool, specifically the Venous Leg Ulcer risk assessment, to predict the likelihood of wounds not healing. As well, in this session, we will look at assessing the role of geko device as a first-line adjuvant therapy in the treatment and management of venous leg ulcers. Next slide. So in 2016, there was a previous evaluation that Mississauga Halton LHIN conducted in the use of geko, which led to the device being added to the LHIN's formulary in 2017. It also led to the development of our current policy and procedure. And about 6 to 9 months after the addition of the geko onto the formulary, we had an opportunity to revisit geko use. And we noticed that we did this review, and we started at about 6 months, took us closer to 9 months to complete the review. And we noticed that geko, although it was added on the formulary and was very accessible for clinicians, we had a PNP, and there was a very systematic way of requesting the device. It wasn't actually utilized until approximately 90 to 100 days into the patient's care plan. Our current policy does state that adjuvant therapy such as geko should be considered if the wound fails to reduce in size 30% at 30 days. So this led us to the question, was there a disconnect between calculating the percentage reduction in wound size at 30 days and identifying when adjuvant therapy such as geko should be started? Next slide. So the aim of the Quality Improvement Initiative, which this question was developed, and we wanted to see if there are ways we could actually improve our policies and procedures by doing this QI initiative so that patients could have early access to the device, ultimately improving patient outcomes and experience. We also wanted to have an understanding of the patient's perspective of their wound and its impact on their quality of life. So in a few slides, we will be looking at some of the qualitative work that Dr. Janet Kuhnke did in parallel to this QI initiative.
Patients with venous leg ulcers were admitted to the community clinics of Bayshore and Care Partners nursing agencies within the Mississauga Halton LHIN, where they were seen by a wound specialist who did their assessments. 11 patients meeting the inclusion criteria were evaluated on their first specialist visit using a combined lower leg and a venous leg ulcer risk assessment tool. The specialist then revisited those individuals in 2 weeks in order to repeat that risk assessment and see if there had been any change to the score. The venous leg risk assessment tool is a validated tool used to predict the likelihood of a VLUs failure to heal within 24 weeks. It's a tool that was modified with permission for this evaluation. And the intent of this initiative was to use the score that was generated in order to give clinicians a very early idea of which wounds were most likely to move down a chronic pathway and to trigger a recognition, a realization of the need to use the geko device much earlier as a first-line adjunctive therapy in order to improve a wound healing outcome. The scores were based on a series of questions and findings, and they were then classified into categories. A low risk for failure to heal is green, and that generates a score of 0 to 5. Moderate risk is yellow, and that is a score of 6 to 10, while a high risk is flagged by red, and that means that the score the individual achieved was 11 or higher. All the patients whose scores were moderate to high at the time of the initial specialist visit were given a geko device. The aim was to have that done within the first 2 weeks. Those people who scored low risk of failure to close at that time continued on with the standard of care, and if at the follow-up visit 2 weeks later that score increased to moderate or high, then they received the geko therapy in conjunction with their standard of care as well. If the patient scored low initially and remained low on the follow-up visit, then they did not receive the device, they continued with standard of care, and they were not a part of this evaluation. What was found was that in the intervening time between the specialist's initial visit and her follow-up visit, 10 out of 11 patients experienced an increase in the risk of failure to close. Prior to this evaluation, as Rochelle said, the average number of days elapsed from patient admission to application of the geko device was 99 days. Throughout the course of this evaluation, the average time elapsed between admission and application was 48.9 days, which is a significant increase. But we have to remember that our aim here was to initiate within the first week to 2 weeks. And what we found was that a significant number of those delays were related to a need to access vascular studies. At the time the wound specialist made her initial visit, she documented 15 wounds in 11 patients. By the time the geko was initiated, 10 wounds were documented in 9 patients, and 2 of the patients did not have any documentation in their charts on the day of the application. So during the course of the evaluation, 12 of the original wounds healed. 2 of the wounds remained open, but they had an average reduction to surface area of 88%. And 1 wound that was previously closed reopened. This is a graph that displays for you the mean daily healing rates before and after application of geko. So on the left-hand side, what we're looking at is the run-in time, or the delay time, during which patients received only the standard of care, no geko application. And we can see here that there really isn't a whole lot of movement in terms of healing. On the right-hand side, this is a depiction of the application of the geko device and the impact on healing. And you can see that it's raising the bar to just below 1.5% per day.
And this graph shows a comparison of percentage wounds healed before and after the application of geko of the 8 patients that had their wounds completely closed. And you can see the significant difference between pre-geko versus post-geko. Next slide. So ultimately, the findings that, that we could share with you with this quality improvement initiative is that without the use of geko for those wounds that came to full closure, with the Mississauga-Halton-LHIN, the average healing time without geko is roughly about 15 weeks for those that did come to closure. Healing time with the geko device added is an average of 12 weeks, which definitely occurs with the early intervention and use of geko, and ultimately with the shortened length of stay improves not only the healing outcomes, but it also decreases nursing visits as well, and potentially can decrease costs. And as I had mentioned previously, Dr. Janet Kuhnke also ran a qualitative study with the patients that were on this QI initiative. And really what she did was explore what the experiences of those patients with wounds, specifically venous leg ulcer wounds, what that experience would be for these patients. And she spoke to these participants and reviewed some of the consequences of having a venous leg ulcer, explored that. These were conducted via telephone interviews. She did follow-up calls. And really what the ultimate goal was to get a better understanding of, a patient's experience with a venous leg ulcer, and then what it looked like after the use of, or with the use of adjunctive therapy.
So when Dr. Kuhnke did that follow-up telephone survey, there were several emergent themes that patients brought to light, one of which was pain. Every single one of them identified pain as having a significant impact in their life, whether it impacted their emotions, whether it impacted their relationships with caregivers, made them more dependent, it changed their functional status. They all identified that, as well as the fact that they were all able to articulate that there had been a change in their perception of the pain that they were experiencing and the impact it had on their life throughout the evaluation as they used the geko device. And what we found was that they all had reductions in their level of pain, and they, a lot of them had a cessation in pain. When we're dealing with wound care, we have to look at this holistically, not just the hole in the person, but the whole person. We all know that. You can't look at holistic care without dealing with an individual's mental health. There's a need to attend the psychosocial aspects of that care. We need to listen, and we need to respect what people say. We have to provide encouragement and constant reinforcement in order to gain the trust and to build that hope and the optimism. There is a growing body of evidence that does still need work, that does indicate that when an individual is optimistic, when an individual is hopeful, there are increased levels of dopamine and serotonin. And that causes an improvement in wound healing. This evaluation revealed universally that these individuals were able to express hope. They were able to express optimism. It may have been in the belief that their wound was going to close or shrink. It may have been, oh, thank goodness, less trips to the clinic, less rearranging my life, less decrease in my functionality, maybe no more pain meds or less pain meds, finally being able to wear their own pants and socks and shoes like we heard about in the edema talk. These were all universally expressed. These are just two of the quotes that Dr. Kuhnke took from patients that she interviewed during the qualitative arm of this investigation. And it demonstrates the ideas of optimism and hopefulness. And Dr. Kuhnke goes into a great deal more detail in her poster that you can access in the poster hall, as well as providing you with a number of her references there. This material that she's worked on is currently in preparation for publication.
So some of the take-home messages from this quality improvement initiative, which is very similar to what we learned with our initial evaluation with geko, is that early intervention of geko would be appropriate in basically seeing positive results, positive patient outcomes. But more importantly, because we saw such a delay with the application of the device initially, we noted that using a validated risk assessment tool really helped trigger clinicians into when to consider adjuvant therapy such as geko. So this is something that we saw significantly improve from, again, the 100-day, 99 to 100-day application, which was taken down to the 48 days with the use of this validated risk assessment tool, which ultimately decreased the amount of time it would take for the patient to have access to this device. We noted that the wounds also tended to deteriorate with the weight to use or have access to geko, and a lot of the weight was due to accessing vascular studies. So what we've learned is that ultimately geko device can be added to essentially the care plan or the standard of care while waiting for vascular studies. We noted that vascular studies were being waited on and were more appropriate when it came to identifying the type of compression applied to the leg, rather than having the value to safely apply geko as a therapy. So that's our presentation. If you'd like to learn a little bit more about the Quality Improvement Initiative, we do have a poster that is also being displayed in the poster hall. So you can feel free to read a little bit more on what we did at the Mississauga-Halton LHIN in collaboration with Perfuse Medtec, as well as with Care Partners and Bayshore.
Okay, thank you very much. And we have a list of references up. We want all the speakers to unmute and to join us back. And we do have some questions from the audience, and we can go to those questions now. And so one of the big things that always comes up is funding. And how is geko funded or supported in various LHINs? Those are for everybody across the country, local health integrated networks in Ontario. And there are 14 LHINs across Ontario. And I do know that 6 of them fund the geko. So they are Central, Central West, Mississauga, Halton, Erie, St. Clair, Southwest, and Waterloo, Wellington. And others are considering it. But in Ontario, we're actually moving to 5 health districts. Kathy, do you want to comment on other constituencies that fund the geko or that are looking at the geko now? And I think there's some consideration in British Columbia.
There is, Gary. We're just started an evaluation in BC about a month ago.
Yeah.
And funding here in Nova Scotia, geko is accessible. There is a process that it's like a special request that has to go to Department of Health, and once it's approved, then they will give 4 weeks of treatment and then reevaluation. And in New Brunswick, it's on MedBuy, so they have full access to the device to put their patients on.
Okay. Very good. Anybody else got any comments on availability of the geko device? Rochelle, you certainly got it available in Mississauga-Halton.
Yes, at the time that we actually didn't initially have the funding for geko prior to the evaluation. The initial evaluation that we had really helped to essentially put together a business proposal in showing that the use of geko can increase patient outcomes and shorten the length of stay, which we utilize to showcase that with an upfront investment, you can see downstream cost savings. So at the time, we had a very innovative VP who was very much a forward thinker and a big supporter when it came to reviewing some of the therapies that was available within our LHIN for wound care specifically. So that was part of what allowed for geko to come onto our formulary. It was a little bit of a risk, but it was something that paid off. And we want to maintain this device on our formulary, which is part of the reason why we put together this quality improvement initiative to ensure that because it's accessible, it would still continue to be available and that clinicians could know when to consider use of it. And we did that with the validated risk assessment tool to assist with that, which we'll be looking at modifying our policy and procedure to include.
Okay, that's great. Robin, one of the things I see with any device is the fact that treatment hasn't been optimized when people want to put the device on, or they may have the wrong diagnosis, or there are other, maybe this is a maintenance or a non-healable wound. How do we improve wound care and interprofessional care? Put your hat on as the lead at Women's College in the clinic.
Of course, I think making the right diagnosis is ultimately the most important thing. And we do run into some maintenance wounds, but I think in relation to the geko, I think it's something it's now available in my local LHIN where more of my patients are. I do have patients that are stalled wounds, and I think I can see now that a lot of it is because we can't get proper compression on these people for various different reasons. And I think, having this geko device will certainly pull that forward for us. So I think it's something we need to maybe consider some of these adjuvant therapies a little bit more earlier on in some of our more difficult to treat, and what we consider, we see those patients that really don't have a calf muscle pump at all. And we've got venous leg ulcers and we're trying to compress them. We're not doing a great job at that. I think this is the ideal situation for the geko in our clinic.
Okay, and thank you, Catherine Robson, for that question. Now, I have a really difficult question, and I will leave it open to the panel. From Marie-Philippe Mercier. Good morning. We can see the device is applied on the fibular common nerve, so it's really the common peroneal nerve, on the lateral part of the leg. This nerve innervates the fibular muscles, and that's true, which making an eversion of the foot and not a plantar flexion of the ankle. The plantar flexion is what activates the muscle pump. I'm confused as to how it works to perfuse the medial part of the leg and activates the muscle pump. Thank you. Now, who on the panel is going to help me? Kathy, do you want to start off and give me some help on how this might work? And then we can look at other responses and ask the panel members to really give us some insight.
Well, with geko, it is placed over the common peroneal nerve, and it activates once per second, and there's 10 settings. So what you do is you increase the settings until you get that twitch, and what it's actually doing is activating sort of an antagonistic mechanism so that the gastrocnemius is contracting. And I think, Carol Ann, you can probably explain this a little more in depth.
Yeah, when the common peroneal nerve crosses over the fibular head, there's a bifurcation. So the main branch goes down and supplies the anterior compartment of the lower leg, and it activates the muscles in that compartment, one of which is the tibialis anterior. Another branch, the smaller branch, moves laterally into the lateral compartment, where it causes activation of muscle through the lateral part of the leg. The nerve then goes down and crosses over the ankle and activates the dorsal foot compartment. Now, when all of those compartments are activated together and working as a team, it causes activation in the posterior compartment passively, because that area has to respond with a stretching situation. So you get an increase in blood flow because you've got elongation of the muscle and compression of the muscle with the contractions going on anteriorly. I hope that helps a bit.
Okay, maybe while we're going on to the next question, we could move the slides forward for the references for a few minutes and then finish off. And there is a slide with 5 emails on it as well. So there's the references up for now. I think this is an interesting question, and Rochelle or anybody can, or Robin can answer this. Why do venous leg ulcers occur most often on the medial ankle? And there are some good answers to that. Any of the panel want to chime in on that?
Robin?
Okay.
Okay, I can start and anyone can jump in. So the saphenous vein is on the medial side, and that is actually the very first change when you get edema due to venous insufficiency. It's the major vein and it's the first thing to go. So you're going to see the first change of venous disease is dilatation of that saphenous vein. So it really all starts down there, and so therefore the medial. It's not only going to be the medial compartment, of course. We see venous leg ulcers occur other places, but that's sort of the sitting duck.
Yeah, and I think, Robin, that's a great start. And the long saphenous has its greatest curvature and it's most superficial over the medial malleolus. And most venous ulcers are in the lower third of the gaiter area, and that's where you see the edema first. So you see varicosities, edema. Then it's leaky to red blood cells, and it leaves hemosiderin and melanin. And when it becomes leaky to fibrin, you get the tree trunk legs or the woody fibrosis. And when that woody fibrosis continues all the way down, so you can't squeeze the skin over the dorsum of the second toe with the thumb and index finger, that's called Stemmer's sign. And then we've got venolymphedema. And we always give the venous first primarily and the lymphedema second. So the question here is it possible to have lymphedema alone? And from my point of view, yes, and you can have it congenitally and acquired. Does anybody else want to pick up on that further? Robin?
Just like you said, Dr. Sibold, there's the primary and the secondary, and what we see mostly is secondary lymphedema. Primary is more of a genetic disease, picked up in adolescence usually, but what we see mostly is secondary lymphedema, and it can be on its own and then can cause problems with the venous system. So people that do have lymphedema in the lower extremity from whatever cause can get some damage to the venous disease as well as a result of just the increased pressure in the tissues. So they often coexist, but they can start out as being totally one or the other.
Good, excellent answer. Now, another question is, what is lipedema? And L-I-P-E-D-E-M-A. And lipedema is a little bit different than lymphedema because it's excess fat. And if you squeeze that excess fat, it causes excruciating pain. And that's really got to be distinguished. And there's an excellent article by Carolyn Fife in Advances, lipedema, frequently misdiagnosed. And these patients do well with weight loss, exercise, and low rather than high compression. But the complicating factor is that some of them can get secondary lymphedema. So has anybody got experience with the lipedema patients that you want to comment?
Well, I think, Gary, just in my clinical experience, what we'd see is just, like you say, once you put the compression on, then the fat or the lipid just redistributes. And then it's not only pain, but you can really cause a lot more damage as far as skin breakdown and ulceration.
Yep, yep. And the last thing you want to do is cut it out. And if they're going to do liposuction, it's got to be done by an expert. And I think they have a much greater chance of making these poor people worse than better. So, you know, it really requires a little bit of knowledge and not getting the wrong diagnosis. But often these people aren't diagnosed till they get to a specialized clinic. Robin, I had a question. Which medication can cause leg edema? And I think you mentioned 3 classes of medications. And maybe you can comment on the fact that we don't use furosemide or diuretics to treat venous disease. You're going to dry the patient out and they'll still have...
Right. Yeah, so it's a common thing. I mean, you don't want to put people on these strong diuretics for many different reasons, electrolyte abnormalities, and, you know, just putting somebody on furosemide, I mean, that's going to affect their life insurance or travel insurance. You really need to have a good reason for that. It means there's, you know, they have a history of congestive heart failure or renal disease. Just trying to get the fluid out of the lower extremity is not a thing that you want to do with furosemide. I see it all the time, and patients are very happy to be off it once you get control of their edema. But you just have to think back to the pathophysiology that we went through. There really is, now that you understand that, really no reason to do it. So an analogy that I've heard before is that if you put a cup full of water and you dump out half of it, the fluid's still in the bottom, and that's the same as what happens with furosemide. You take out half the water, but by gravity, you still have the lower extremity issue. So to my mind, it's a no-no.
Gary, I just want to make the point with the study that was done at London Health Sciences, where it clearly demonstrated that there was increased urinary output. And in my practice here, what happened with an evaluation that was conducted by Amanda Parsons, who was a student of IWCC.
Thank you.
She put a patient on geko, and they had started her on furosemide 3 weeks prior to starting geko. And what was really interesting was that for those 3 weeks, her output was about 600 to 800 cc's a day. Once they started geko, she went to 1200 cc's, then she went to 3 liters, and then she was over 3 liters a day. And when they gave her her day of rest, she reverted right back to 600 cc's. So that tells us that definitely with geko, we're seeing a systemic effect with removing the fluid. It's not just redistributing it, it's actually getting rid of it through the kidney.
Okay, I think good things. Rochelle, I'm coming back to you. I'm very intrigued with your venous ulcer non-healing wrist tool. And is this the University of Queensland tool?
This tool was it Dr. Leslie Parks?
Yeah.
Katie Parker from Queensland, yeah.
Yes. Mm-hmm.
Yeah, and I think it's an interesting tool for people to look at. And they also have a tool that goes along with it on ulcer recurrence rate, because we know recurrence rates are really, really high. And I think if we can look at the people with high risk, David Margolis had a really good article where he identified those factors like previous knee and hip surgery, larger ulcer size, fibrous base, and you know, if they had a lot of woody fibrosis, etc. And it wasn't diabetes or some of the things that you generally think about. And if the ABPI was less than, I think at that time it was 0.8, but that Margolis article is really a very good article, and I think there is an increased risk. Now, there is a question about the cost of the geko, and I know this is not an easy one to answer because I think in different constituencies it has different cost. And
No, Gary, it's the same.
okay, how much is it?
It's $375 a week, which is 6 days of treatment. It goes on for 6 hours per day. It comes in a pack of 3. So one device can be used for 2 days, and then they have their 7th day of rest.
Okay. That's useful. How many weeks is the average patient on geko, Kathy?
Oh, I mean, again, that depends on the chronicity of the wound, but on average, we're looking at anywhere from 3 to 12 weeks. And I think that's your experience, Rochelle.
Yes, we're right around six weeks.
Yeah.
For closure, as long as it's applied at the right time.
Okay, I think we're at time. I'd like to thank all 4 speakers for a great job, Carol, Kathy, Robin, and Rochelle. And I'd like to thank our sponsors for this session. And I hope everybody fills out evaluations, but has a great time at Wounds Canada. And I think you have another edema session coming up that should supplement the discussions you've just heard. So thanks to Perfuse, thanks for the geko, the speakers, and have a good day, everyone. Bye for now.
Thank you.